Yes. Very good afternoon to one and all present here for the webinar. I welcome you all to this webinar on behalf of Department of Geriatrics, BLDE deemed to be University, Shri Patil Medical College, Hospital and Research Center. I, Dr. Vigneshwaran, postgraduate in Department of Geriatric Medicine, will be the master of ceremony for this session. I'd like to invite our head of department, Dr. Ananthi Ambri sir, to give a brief introduction about the today topic and to introduce chairperson and faculty for this session.
Thank you, Dr. Ganesh. It's indeed a great evening today. We are going to discuss regarding loneliness in the older people, and we have stalwarts with us to discuss the things. So we at the geriatric clinic since 2007 have been serving the older people at this part of Karnataka. We are the first in North Karnataka to start geriatric medicine, and we also have adopted a village for senior citizens where we provide free medicines and free health checkup every month on 4th Sunday, and that has been endorsed by United Nations. So it is our we want to create awareness about common diseases in older persons across multiple stakeholders. So in that connection, again today we are having a discussion on loneliness in elderly. We at Geriatric Clinic and on the behalf of Geriatric Medicine, BLDE deemed University, Shri Patil Medical College Hospital Research Center, I welcome all the delegates and our speaker and our chairperson for this program. I take this opportunity to introduce Dr. Debanjan Banerjee. Debanjan Banerjee has completed his post-graduation from NIMHANS. He has also postdoctoral in geriatric psychiatry. Very few people go for this. And he is affiliated now presently with Apollo Multispecialty Hospital, Kolkata as a consultant geriatric psychiatrist. Sir is a recipient of several awards, including the gold medal in MBBS, Best Resident, Best Psychotherapy, the Gandhi Fellowship Award, ICMR Young Scientist Grant, and World Psychiatric Association. Sir is the convener, Geriatric Psychiatry Section, SARC Psychiatric Federation, and Vice Chair, Public Advocacy and Awareness Committee, International Psychotic Geriatric Association. Sir is also Deputy Editor-in-Chief, Journal of Psychosexual Health, and Associate Editor, Journal of Alzheimer's Disease. Sir is a recipient of many awards, and he has 100 publications in index journals to his credit. And he is a regular columnist for several Indian dailies, national dailies, in fact, New Indian Express, the Telegraph, the Quint, and the Indian Express. So, sir, I welcome you for this unique program. We also have Mrs. Anjali Raje, madam, and she is now the Executive Director of International Longevity Center, Pune. And as a member of ILC, Pune is a member of Global Alliance of the International Longevity Centers and an NGO. It enjoys a special consultative status with United Nations Economic and Social Council. It is also the satellite center for SARC region of the United Nations International Institute of Aging, Malta. This is what they do. They organize the international training program, the certificate course on social gerontology biennial. And I was a part of this program in 2014, where in the photograph you can see a madam there when I was giving the feedback for this program in 2014. The unique initiatives that are being carried out by International Longevity Centers are Happy Hours Cafe, Mobile Literacy Training Program, and many more. According to the ILC, they are doing a lot of work for the benefit of the older people. So why we should discuss about loneliness in the older people? So the loneliness in older people is now overtaken the depression among the older people. So loneliness is so common, but unidentified or underdetermined. And most of the older people also don't come and reveal what they're feeling of. Recently, even we did a survey in various old age programs where we go as an faculty. There we found that out of 60 people who have filled the form or loneliness screening program, 8 were having loneliness. So that's a great impact. Though they were attending the programs with us and all, but they're still feeling lonely. And it has so it gained so importance in the Western countries that there is an already a department or separate ministry for loneliness in United Kingdom. And as we all aware that the loneliness leads to negative impact on the health of the older people. It reduces the survival rate, it leads to again depression, and they become socially isolated and have a lot of negative impact on their mental and physical health as well as the quality of life. So discuss all these effects on elderly population. We today have Dr. Debanjan Banerjee to discuss in detail how to identify and what measures to take to prevent loneliness in the older people. So in this regard, we have people joining here. So we have Dr. Debanjan, sir. So over to you, sir. So you can, over to you, Dr. Debanjan, sir. Thank you so much for joining.
Yes. So am I audible?
Yes, sir, you are audible.
Yes. Thank you so much. Thank you, Dr. Anand. It's such a pleasure to be here in this forum today. And my regards to Dr. Raji and the whole of the audience here. Actually, we have been planning on this for quite some time, and I'm glad that finally it happened. And my regards to the Department of Geriatrics. I think you really are doing a fantastic work, and there are multiple programs which I also closely follow. And it's very important that we have this cross-disciplinary discussion because, as we always say, that geriatrics practice cannot happen in isolation. So I will share my screen now, if that is okay. So just are the slides moving and are they visible?
Yes, sir. They are moving, they are visible, and you are also audible. Please go ahead.
Yeah, perfect. Thank you. So just feel free to interrupt and stop me anytime if you see that the slides are not visible or I'm not audible or there are any technical glitch. Warm welcome to you all. And what I'm going to do in the next 20 minutes, 30 minutes or so is probably take you through the different facets of loneliness, particularly in older people. Loneliness is a huge topic in itself. It has medical, social, spiritual angles to it, many more. So I'll try to be as brief as possible, but I'll really be interested in your perspectives and discussion that follows my presentation. So to start with, I think this is one of the, how do I put it? One of the ways where loneliness can be described, that it's a feeling of being unwanted. And this quote has been taken from one of the speeches of Mother when she was addressing how homeless children, they sometimes feel lonely, and how loneliness is a very, very subjective feeling. It's very difficult to quantify it using a scale per se. I'll come to assessment of it, but then the subjectivity forms a very important part in discussing loneliness. I just thought of before we start off, and so that we can make it interactive, I think all of you have access to the chat. So just a quick 30 seconds exercise. When you see this very, very famous painting by Van Gogh, what is it that strikes your mind? This can be a very quick projective test. You can simply put it in the chat. What is it that strikes your mind? Fast. Anybody? Depressed? Okay. Sad? Go on. Just type happy or sad. Okay. Anybody else? Let's not feel lonely here. All of us are together. So quick. Okay. Old and alone. Depression. So most of you think that this person is, feeling rejected, feeling depressed. Fine. Thank you. Thank you for your responses. Suicidal. Okay. Now, it's a very interesting story behind this painting. Van Gogh, we all know that he suffered from bipolar disorder. Towards the later part of his life, he also had extreme form of psychosis. So when this painting was done, this was uh, when he was actually confined to a solitary cell, and food and water was usually passed to him through the door, and he was rarely able to go outside because he was extremely secluded from the society. That time he only had his sketches, and he was confined totally away from his common populace. So that was the time when he made this painting. And probably, and one of the time when we have a theoretical discussion around paintings, this is one of the paintings used to probably describe how a person feels when a person is isolated and lonely. We don't know what he had in his mind though, but this is kind of considered to be one of the classical paintings of loneliness. Well, what do we know about loneliness? Dr. Anand was mentioning that it is akin to cigarette smoking, and it's very, very true. Loneliness is almost like a silent epidemic. We don't talk about it much. We talk about social isolation, marginalization, exclusion, but we don't talk about loneliness. To just put it in one word, it can be defined as the subjective experience of perceived lack in quantity or quality of social relationship. Now, this statement is extremely important. Why? I can feel lonely even in a family of 10 members. I can feel lonely in a shopping mall. I can feel lonely in my work, at my workplace with 100 colleagues around me. I can feel lonely in a group. I can feel lonely with my partner. I can feel lonely even when I'm taking care of an entire group altogether. Many of us have read the accounts of different war generals during World War II, where they mention that in spite of being all time around people, commanding them, they still felt that they had nobody to talk to. So loneliness is not just about the number of social connections you have, it also matters what is the type of social connection. Also, it is linked to multiple negative health and economic outcomes. And it is, I'll come to the researches later on. There was a systematic review, 2019 or 2020. It mentions a 50% greater likelihood of mortality. I mean, all of us who deal with dementia, I'm sure will agree that after this COVID, after isolation, it has been quite a remarkable progression in terms of cognitive decline, because the emotional component is extremely important in neurocognitive disorders. And to look at it in terms of population attributable risk, if an effective intervention can be developed to reduce the experience of loneliness, the future healthcare use can be cut down by 17%. So loneliness is costly. It may lead to multiple negative adverse consequences, not only on the individual, but also on the society at large. Now, these are two words which are often used synonymously, but they are not. solitude, which is a very, a very widely used term, it differs from loneliness in being it's a positive and a constructive state of engagement. Sometimes all of us feel like staying alone, staying to ourselves. We sometimes get very tired and we feel like, okay, I'll rest. I just don't want any interference and I will have a wonderful company by myself. That's a state of self-reflection and positive engagement. Solitude cannot be permanent. It cannot be continuous. So loneliness is a subjective state of feeling deprived, whereas solitude is a self-determined state of being alone without feeling lonely. I think that forms the major difference. This is a wonderful article by Brunetti, and it's again freely available. If I remember correctly, it's an open access, which talks about how there are different objective and subjective measures of understanding loneliness. Remember again, loneliness and social isolation are not synonymous terms. We spoke a lot about social isolation during the COVID times, but loneliness is a subjective thing. Objectively, it is measured by social isolation. Similarly, solitude, it's a state of voluntary aloneness. However, the objective measurement is when person has nobody around him or her for quite some period of time. Solitude is associated with self-reflection, rest, relaxation, escapism, which increases fantasy thinking, constructive fantasy thinking, and sense of happiness. Now, social isolation refers to a quantitatively diminished social network. But as we discussed, social isolation can increase the risk of loneliness. But if you increase the number of social connections, automatically you cannot reduce loneliness because the quality of the connections also matters. I may be among a huge crowd, but I can still feel that I don't have anybody to share my feelings. The types of loneliness we will discuss next. So most of the research of loneliness comes from the initial concept given by Weiss, W-E-I-S-S. There is on loneliness by Weiss. I'll refer to it towards the later part of the talk. Social loneliness refers to the perceived lack of quantity as well as quality of relationships. I am in an office where I work in a separate cabin. I don't have people to talk to. Also, the few people I have around me, I don't have a good relationship with them. Emotional loneliness describes the absence or loss of meaningful relationships that meet a deeply felt need to be recognized and belonged. I have a lot of social connections. I go to conferences, go to parties. I have my own network, personal and professional, but I don't really have anybody with whom I have that emotional resonance with which I can share if I feel something has, gone very wrong with me or a day has gone bad. So I want to talk to somebody about it. I don't have anybody. Existential loneliness refers to an experience of feeling entirely separate, often when confronted with traumatic experiences or mortality. Now, existential loneliness is a component which is discussed and studied a lot in context of spirituality. Again, I will refer to it a bit later during my talk. But often, if you look at individuals with near-death experiences, again, I will keep referring back and back to COVID because a lot of discussion and studies on loneliness have emerged from that period. So those who were in ICU setup, doctors who were taking care of patients continuously, who were very ill and who were on the verge of death, individuals who have post-traumatic stress disorder, they have felt this when there is such a threat to your existence. After that, you do not feel that you are able to connect with people. You feel that in that entire experience, you are alone. Individuals who suffer from sexual assault, war conflicts often face this kind of a reaction. Now, this is again fantastic review. It's a conceptual review of loneliness across the whole adult life course and what works for well. So it's a paper by Mansfield et al. In 2019. And if you look at it, the factors which promote loneliness are long-term illness or disability that can be physical or psychological, unemployment, single or separated from family or your spouse, both age extremes towards the lesser part, 16 to 24, as well as senior citizens, older people. For women, it is not belonging, feeling that they don't belong to, the sense of belonging not being there, and for men, not being able to professionally or personally connect. Education has a direct relationship with loneliness. And if you look at this data, 5% of adults in England often, may I please request all of you to just mute yourselves, please? Thank you. And 5% of adults reported feeling lonely in 2016 and 17. Remember, these factors have been taken from a self-report by participants. So long-standing loneliness, chronic loneliness is linked to poor physical health, mental health, and poor personal well-being. So it's very important when we talk about quality of life, loneliness is an important factor to play. Now, coming to the impact of this, we all know that the world is rapidly aging. Individuals, 60 plus or above, they are set to double by 2050. Today, most of us are sitting and talking in India. South Asia is one of the areas which is aging faster than the rest of the world. We all talk about dementia, the demographic transition, and with this transition, the problem of loneliness comes all the more because the family structure is changing. And many times this, post-COVID, during COVID also it came to play. Above 50 years, 60 years, individuals continue to stay alone. And in fact, even if we talk about staying connected digitally, digital literacy is not really great in most of our countries in South Asia. At least in India, the rate of digital literacy is roughly 8.1%. If we talk about the national average, imagine how much that can be considering the number of older people. In a nationwide survey, more than 1/3 of older Americans said that they are lonely. And in India, based on the longitudinal aging study of India first wave, 11% of older people felt lonely most or all of the time. So yes, we need to be concerned. And again, once again, I'm glad that this discussion is happening. Now, why talk about old age? Loneliness affects all age groups, right? So why are we especially concerned and talking about older people here? Of course, Department of Geriatrics, and Dr. Anand is a geriatrician. I'm a geriatric psychiatrist, but the story is much more important and beyond that. Most of the study of loneliness has been done in older people. Why? Because there are certain vulnerabilities that specifically affect this population. Remember, when I am being lonely, I am being cut off from my surrounding social structures. Why? Number one, sensory deficits. I don't see properly, I don't hear properly, so automatically I will not be able to participate as I was before. Cognitive decline, memory issues, all the more a meaningful social participation will be impaired. Frailty, the biological vulnerability of older adults, that is something which is of concern. Limited mobility because of multiple reasons, pain, osteoarthritis, multiple surgeries, risk of falls, the mobility is more limited. So I am not able to travel to places as I was before. Financially, many older people are dependent. intergenerational bonds, a very, very important area to talk upon, have been failing at many areas. As I said, family structures are changing. Social isolation. We know about empty nest syndrome, where after the children are launched out of the family, older parents are mostly staying alone and in isolation. I already mentioned about limited digital literacy, the risk of elder abuse, which is very high. And for that, some people shift to residential care facilities. Some do not feel comfortable to stay in a family. Lack of social participation. How often have we just shunned off our parents and grandparents, telling, this is something I understand and I'm dealing with, you don't interfere. When we do that, probably we do it in a good sense. We don't want them to bother about something, but then ultimately we are depriving them from a meaningful participation in what they had been doing all their lives. Late life or geriatric depression, which is perhaps an illness in itself. I mean, we can have 5-6 sessions on that alone, but that again restricts a person's involvement in his or her social structures. And finally, not everybody can stay at their own homes. And when they move to residential care facilities, the social contact sometimes gets diminished. What issues are often missed in these cases? Who are probably more vulnerable? Those who are caregivers. Remember, we always talk about individuals who live with dementia, but what about those who care for them? Unless we have caregiver meets, group meetings, we involve them in a group together, it's very difficult. Sometimes they feel very isolated and lonely. Poverty, grief, bereavement. Those who have lost their children, their spouses, something which was rampantly happening during the COVID waves. Retirement. Trust me, most times when I see somebody, some gentleman or some lady, I see that after retirement, their whole life structure, mood, everything has got changed. And geriatric depression and cognitive decline has a very, very important take on retirement. Neglect by families, which again amounts to elder abuse, and the vulnerable populations like the sexual minorities, the gender minorities. So individuals who have LGBTQIA identity, for them it may be difficult because all the more they are marginalized and they probably suffer from double marginalization. Chappell and Bajer in 1989 had given certain overall risk factors for loneliness. I think we have covered most of them, but just some additional ones are emotional issues, phobias, financial challenges, those who have high neuroticism traits in personality, which we term as cluster C personality, and changes in family structure. In 2015, the National Seniors Council of India published a manual on loneliness. It was a very well-researched manual, and they came up with these risk factors: living alone above 80 years, chronic health problems, cognitive sensory deficits, everything comes in that, lack of contact with children, difficulty accessing transportation, changes in family structure. So this is what we have covered, the entire gamut of risk: age, ethnicity, geography, health and disabilities, areas where you stay, understanding about the social security benefits, understanding how I can be involved in the society and how I can contribute meaningfully. Many older people whom we see, whom we talk to, they do not have the understanding that how they can still, with their limitations, be a part of something. And that is where we need to intervene. Now coming to the various studies which have spoken about it. This is again a wonderful paper published in a not so well-known, but again a good journal, Wellbeing, Space and Society. So exploring the determinants, what are the risks and what are the mitigating factors? These were the questions asked. What are the risk factors in community-based older adults? How does it explain the feelings of loneliness? Which demographic groups are more vulnerable? And whether it has any policy implications. These were the highlights of the study. The risk factors, were multidimensional. Social isolation and neglect are major contributors to loneliness. There is probably a gender divide. Older single women living in low income with lower literacy rates are at greatest risk for loneliness. Community social support. So having a close-knit community support is a critical factor in lowering feelings of loneliness. I think all of you should just have a look at this manual. It's a small manual, but it's a wonderfully published one by World Health Organization very, very recently. So this is one of the documents of the United Nations Decade of Healthy Aging from 2021 to 2030. It's an advocacy brief and it beautifully covers most important areas. So just based on data, in most countries, 1 in every 3 older people feel lonely. So just by that statement, imagine what can be the magnitude of the problem. Again, this is taken from the manual. What are the risk factors or what are the effects? So direct effect on mortality, multiple health conditions, cardiovascular disease, high risk of repeat AMIs, CVS, diabetes, depression, anxiety, cognitive decline, metabolic risk factors, sedentary lifestyle. Dr. Anand was mentioning about smoking, increased risk of smoking and alcohol, low physical activity, high risk of frailty, cognitive decline, impaired mobility, increased economic costs of healthcare, impaired quality of life, high risk of elder abuse, high risk of institutionalization, high risk of suicide. It's a vicious cycle. So when a person turns old, there are existential fears, problems in distancing, illness, loneliness, issues with misinformation regards to health, existential issues as to what after me, and along with that, there are multiple problems that increased during the COVID times. They had problems with how do they do their daily chores because most of the time house helps were not there. They were living alone, issues with digital connections, and ageism was very rampant. Many individuals could not distance themselves from loved ones even when we were talking about social distancing. And there was lack of basic amenities. We were not able to, some areas, I remember in Bangalore, many organizations were working to probably reach the basic amenities to the older people, but at many places, they didn't have even proper access to medicines or food. Again, this is a 5-year poll data. The University of Michigan did a national poll on healthy aging. So this 2018 to 2023, that is pre-pandemic to post-pandemic times, shows this trend. So if you look at it, it's 27% increasing in 56% during COVID and gradually reducing. The percentage of adults who experience loneliness have actually reduced to pre-pandemic times. But these were the individuals who didn't face this. This trend was not seen. So the decline in loneliness percent was not seen in those who had mental health problems, physical disabilities, vulnerable communities, and those who had infrequent social contact. These individuals did not have a decline in loneliness even after the pandemic was over. These are the findings from the Irish longitudinal study on aging. We have many studies on age, longitudinal studies on aging. Our own Lassie is modeled on the health and retirement study, but these findings were a classic publication from one of these, the Irish study of aging, which talks about loneliness and social isolation. Now, we know that Ireland is a very well digitally connected country. but 1/3 of adults experienced emotional loneliness, at least in some time. Poor self-rated health, lower education, and chronic conditions were associated with higher levels of loneliness. Those who felt lonely, they had felt high neuroticism, that is high degrees of anxiety, increased depressive symptoms, and poor quality of life. And one important thing, many times when we discuss loneliness, we say that social isolation is a part of aging. No, that is not true. A person does not have to necessarily feel lonely and be isolated as he or she ages. This is a paper that was published in COVID-19 times, and it talks about the concept of social frailty. I personally felt the concept very interesting, so I thought of presenting it. Like biological frailty or frailty, there can also be something with social frailty. Besides the different factors, the wear and decay of the body, the inflammatory state, the oxidant response that actually leads to wear and tear of various organs and aging, social isolation, perceived loneliness, social inequalities, marginalization, risk of abuse, all of this can actually lead to a social vulnerability, which can contribute to social frailty as well. So I may be very well fed, I may have all the amenities near me with me, but if I do not have social support, I can still suffer from frailty. That is the message that goes on with this paper. So physical and social frailty needs these factors. Remember, it's not just about depression, diabetes, hypertension, osteoarthritis. Biological factors are a part of it, but there are certain other things necessary. Having somebody for support, cognitive balance, food security, and social security. Social security benefits are an area where we significantly differ from the Western world, and a meaningful participation. I always used to go to the marketplace. I met my friends there. I used to shop based on my requirements. Today, I am unable to do that. Even that can be a measure, or that can contribute to my loneliness. This is from our very own Lassie study published recently in 2023 by Shankar and Ravi, where the role of working conditions and food security is very important in deciding loneliness. So food security, working in unpleasant conditions, and working in isolation, all these factors can increase loneliness. So it's many people may think that loneliness is a very fancy term, but it is not. It's a reality, and probably we need to have a reality check. This was a survey done by the American Association of Retired Persons, and it looks at the different aspects of loneliness. Why I wanted to highlight this is that technology holds a promise in reducing loneliness. True, all of us were able to connect digitally, but it is not a substitute for human-to-human interactions. So this is another website, connecttoaffect.org, where you can go to, and they have very interesting infographics about loneliness. I wanted to stress on this, though this is not directly related to our topic today, because we are having this discussion on 14th of June, and just tomorrow, 15th June, is the World Elder Abuse Prevention Day. So we should take this opportunity to understand that elder abuse can promote, increase the risk of loneliness, and can also be a consequence. It's very common. It's not just physical. There can be different forms of abuse. And remember, it's a silent evil. Most of the times, you do not ask, they do not tell. So if you do not detect it, you will never be able to tap into the emotional pain an older person is undergoing. And the root cause is ageism. The World Health Organization has published a very concerning report just in 2022, where they mention 1 in 2 people are against older people. They feel like that. So remember, 50% of the whole world has ageistic tendencies. And intergenerational interventions. building intergenerational bonds is probably the way out, the way forward. How we think, how we feel, and how we act determine ageism. And I think even if every single person present here take a moment and promote rights of older people and fight against ageism, the goal of this seminar is successful. Just to briefly mention social cohesion, it's a concept which talks about connectedness and solidarity, often studied in sociology. It measures the concept of plurality and collectivism. Basically, it talks about increasing the sense of belonging and interpersonal relationships. This is one of our papers we had published at the time of COVID, and we had conceptualized that the marginalization and exclusion happens on the background of all these factors: ageism, sexism, frailty, lack of social benefits, loneliness, dependency, and abuse. And it can be mitigated not just by medications for depression and by security benefits, but neighborhood, community intervention, social relations, improving financial support, and civic participation are all essential. These are a couple of papers talking about social cohesion. This is the basic concept taken from this paper, that participation, your own capacity, community cohesion, staying together, or simply if I need something, I can go to my neighbor to ask for help. That degree of freedom or independence and feeling safe, I think these are the components which are extremely important when we talk about social cohesion and how it can prevent loneliness. So if any of you are interested in a research or a thesis on this, it's a wonderful idea. This is a global strategy and action plan discussed by WHO in 2016. And if you look at it, the last two, build and strengthen relationships and contribute meaningfully to the society, are essential components to mitigate loneliness. Now coming to the factor that, okay, all this is fine, but how can we deal with it? What can we do to, for individuals who feel lonely? Now, this is a study that was done this was a systematic review and meta-analysis. It's only one of its kind, the largest one and the latest one published in 2022, 70 studies with 8,000 plus participants. These were the interventions: animal therapy, multi-component, lifestyle and social support, exercise, group therapy, cognitive behavior therapy, and technological interventions. None of them showed very robust results, but one of the reasons can be that there were very small number of studies in each group and the studies were significantly heterogeneous. This is a paper which I really love reading, that what really works. Let's say today I am sitting and planning that I will plan an intervention for loneliness. So what are the factors I need to keep in mind? Use of in-between session interactions, inclusion of very clear learning mechanisms. The people should feel that they are participating, number of opportunities for inter-individual and group interaction, and it needs to be a person-tailored approach. Sometimes simply going to a person's home for once a week or 2 times a week and talking to them actually helped loneliness in many studies during when COVID times were gradually getting off. They mentioned that in-person connection is as good as a digital connection, and most of the time it comes up that we need to focus on intergenerational bonds. This, however, talks about something differently. This is a Cochrane review on whether video calls can reduce social isolation and loneliness in older people. Studies were very few, mostly from China, Japan, and Taiwan. And interestingly, the answer is no. Video calls are not effective in reducing. I think somebody is using their marker, so I request, it's getting a bit difficult to read the slides. Thank you. This is one of our review articles, which we had published in our Indian Journal of Geriatric Mental Health. It takes a little bit different approach. We talk about spiritual practices as an alternative pathway to action. This article was a result of a deep discussion with a senior professor of NIMHANS, Dr. R.S. Murthy. I don't know if he's present today in this discussion, but I welcome you, sir, if you are there to share your insights. What we spoke about was that, we talk about different ashramas and stages of life in our Vedic traditions. So the last of which is Vanaprastha, where a person actually prefers solitude. So how we look at loneliness, we look at loneliness, our perception can actually help us deal with it. Either it can be a very medico-biological model connecting it with frailty, or it can be an area where there is self-acceptance, wisdom, a constant process of self-reflection, and probably a part of it can be perceived as solitude. This is not possible to discuss in few minutes, but if you look at different studies which have looked at spirituality to mitigate loneliness, they have seen a acceptance and a humanistic approach so that a person can deal with it, because sometimes there are no external interventions possible. This table talks about the different type of interventions we can actually use if we are dealing with loneliness. So how do we study it? So one of its subjective experience, develop spirituality-based resilience models, use certain particular type of spiritual practices. For example, in demands, we used particular form of yoga or worship and try and see if that helps a person to, mitigate or feel less lonely, and also developing life narratives of persons who have actually done this and see whether that can be an example for others. This is again from the World Health Organization manual. This figure, second figure, talks about the different interventions. One is an individual level, one-to-one or a face-to-face communication through CBT, group befriending, psychoeducation, social skills training. Many do not know how to interact. Community level strategies by improving their transport, reducing sensory deficits, providing them with aid, creating age-friendly communities, and finally, the bigger ones through policies, social cohesion, intergenerational solidarity, awareness programs such as this, and reducing marginalization in all forms, including ageism. These are certain books on social isolation and loneliness in older people. Personally, I recommend to read the classic one by Robert S. Weiss, who had given the concept of loneliness. It's a wonderful read, and it actually gives you a subjective realization of how it feels when you are lonely. I'd like to end with this a little bit different statement, that if we want to see a world for older people, when we age, we need to fight for it now. This was the letter provided by my organization, IPA. All of us had written this, supported by the president and the advocacy group chair, and this was sent to the United Nations, supporting an international convention to protect the rights of older people. India is still not a signatory to this convention, so I would urge all of you to support this from your respective places, because we can only make a world age-friendly, dementia-friendly, older people-friendly if their rights are respected. And that is very, very intricately connected with loneliness and risk of elder abuse. To end, we always keep going back to Freud, being psychiatrists. This is taken from the first chapter of his theories on human mind. Concerning the factors of silence, solitude, and darkness, we can only say that they are actual elements in the production of the infantile anxiety from which the majority of human beings have never become quite free. So probably this infantile anxiety stays, and we are lonely from the time we are born, and we depart lonely. But in between, we continuously seek the freedom from it. It's a different way of looking at it though. But thank you once again for having me here. This is my email ID. If anybody of you have questions after the presentation, you are free to make me. Thank you for your patient listening.
Thank you so much, sir, for that wonderful presentation and excellent. You made such a huge topic very simplified, but I understand it has limitations. Everything cannot be covered in 45 minutes, but at least you have put a stepping step where we can go ahead as a geriatrician and all the physicians and all the NGOs people are involved in today's. Now, over to our chairperson, Mrs. Anjali Raje, madam, please.
Hello, can you hear me now?
Yes, madam, please.
Yes. Wonderful, excellent presentation, Dr. Banerjee. Really, it's such a vast topic and you've covered it in as much in depth as you could. Really, really wonderful. And we got to learn a lot from it. You know, until about a decade ago, I think when, especially in India, when we talked about the health of an older person, it generally referred to only the physical aspect of a person, the physical health of the person. It didn't really talk about what should we say, the mental health aspect, the emotional health aspect. But it's good to know that today it has been accepted that when we speak about health of an older person, we are looking at the mental and physical health of the individual, even the older person. Today we had a geriatric psychiatrist, Dr. Banerjee, speak to us. So the disciplines in geriatric medicine are becoming more and more focused and specific on every aspect of geriatric health, which is really good news for India because this wasn't the situation, say, about 10, 15 years ago. So wonderful to have so many geriatricians and people working in this field, the geriatric field, really very nice. Coming to this little topic, I had read in a paper by Carla Perisonotto, Irina Senza, and Kenneth Kowinski, where they referred to loneliness as the discrepancy between the desired relationships and actual relationships. So, as you rightly pointed out, you can live in a family and still feel lonely. You can be married, living with your companion, partner, spouse, and still be lonely because the perception of that individual towards what he wants from the relationship and what he's getting from that relationship is something that is, I would say, different. And therefore, the sense of loneliness comes in. You also very nicely pointed out that loneliness is a subjective feeling. Very true, and that we are in the midst of a silent epidemic in the world because the numbers of older people are growing. So this issue of loneliness is also increasing. There are certain interventions that you talked about which could, help reduce this sense of loneliness. One of the interventions that you spoke about, some of the interventions that could help reduce the mental healthcare cost by 17%. So that's a good kind of positive input from you. And I'll just talk about how our organization is working towards these interventions. Solitude is different from being lonely or loneliness. I think that's a very good point that you spoke about, it being a self-determined state of being alone and very different from loneliness. An eye-opener for me especially was the kind of three kinds of loneliness that you spoke about: social, emotional, existential loneliness. Very, very important for us to understand when you're talking about loneliness. And when you spoke about the predispositions to loneliness due to old age, one of the factors that you spoke about was the lack of social participation, where the elders are said, okay, elders are told about, kind of take a back seat, don't give unwanted advice and this and that. That smacks of, as you know, ageism, discriminating against a person due to his age, which also leads to a sense, to a loss of self-esteem or self-worth, again contributing as a risk factor towards all the mental health issues that an older person can, be open to, vulnerable to. While speaking about the interventions, as I mentioned, the 1 minute, I'll just start my video. I'm unable to start my video, just a bit. I'm trying. Okay.
Yes.
Yeah. Pardon?
To enable video for all. Because for many it is not enabled.
Okay. That's, I think, a choice. We can leave it to everybody. the speaker can usually have the video on, or the others can join in. That's, I think, a choice for everybody to follow. International Longevity Center India is a not-for-profit organization working for the cause of population aging since 2003, founded by the late social scientist of international repute, Dr. Sharat Chandra Gokhale, Dr. S.D. Gokhale. Our present president since 2008 is Padma Vibhushan Dr. Raghunath A. Mashelkar, and our chairman is the Director General of Police, former Director General of Police, Mr. Jayant Umranikar. All of them senior citizens, but active senior citizens. So we are happy to have them as inspirations and iconic models for population aging. As I was saying, some of the interventions that ILCI has undertaken to dispel loneliness, especially during the COVID-19 pandemic, was we had already started these mobile literacy training programs for senior citizens from 2016. So when the pandemic struck, those of them who were trained in this found this to be a very good, effective way of being connected socially also, despite the social isolation ban put on them. But you also very importantly mentioned that social connectivity is important, but the quality and the types of social connectivity that you have, that is important as well. So an individual, an older person, when we speak about it, has to be engaged in some kind of social or community activity that would help in the development of senior citizens as well as of society in general. So I think that is important. Creating awareness in society regarding ageism, so that they do not treat elders with disrespect, and creating that intergenerational solidarity, or that bond that you're speaking about, is kind of reverting back to our cultural value system that we had, the ancient India had. And we are working towards that through our value education program, where we have senior citizens, especially retired teachers, professors, who have a liking to deal with, interact with children, go to schools, especially underprivileged schools, teach these children through fun and entertainment, through songs, poems, dance, and other such modules, teach them the basic values of respect for elders, respect for women, cleanliness, health, sanitation, because the children come from a background where the parents are unable to give them this kind of cultural input, because these underprivileged schools have children from migrant workers, poverty stricken individuals. So that is one intervention where we try to engage senior citizens in meaningful activity, voluntary activity. So some of these interventions that you spoke about, we are definitely working on to ensure that elders are leading a qualitative, participatory, and productive life in their aging period. And one other thing, you spoke about so many different research studies. You pointed out to us, given us a bird's eye view of all of that, what's happening in this research field in this particular domain. It was truly an eye opener, and I think we must throw open the floor for questions. Dr. Banerjee, thank you so much for an extensive presentation, and Dr. Ambali, thank you for making me a part of this. I'm really grateful to you. So I think we leave the floor open for questions.
Doctor.
Yes, sir. Please ask your question.
Jambunathan, doctor from Bangalore.
A little louder, sir.
Am I clear now? Am I audible, doctor?
Yes, sir.
See, can you just permit me to start my video? You have disabled my video.
No, sir. You can just ask the question and then.
Okay. Doctor, okay. I mean, on the question of this, engaging the elders and talking to them about these various problems they face. And I am from Bangalore, and my name is Jambunathan. I am a volunteer with Nimans. So as a team, what we are to see, there is something known as Vayamanasa Sanjeevini, BMS. So in that program, every week we have got a program on Monday between 4 and 5 p.m. Or see, 1 week it is in Canada, Another week it is in English. And we have also a program in some other languages like Tamil also. See, where we are trying to propagate the various rights that are available to the senior citizens and how to avoid this getting into loneliness, because loneliness is a very, very difficult topic and is a present topic in the minds of people. And this is more related to the mind rather than actually physical one. This is what we have found. Therefore, this is one intervention. I would request people who are able to join. See, Dr. Anand is a regular participant of these webinars. So I would request also all others to join. Therefore, we talk not only about mental issues, we have talk about physical issues also. And most of the the presenters are the experts are from either from Nimmans, good doctors, experienced doctors from Nimmans, or from outside. This is one doctor. Secondly, I think I should appreciate you for one beautiful explanation between loneliness and isolation and being solitude. See, in fact, most of the people feel that the Western concept of loneliness is not applicable in India because here this solitude is happening. Therefore, people can become stay in solitude and will win loneliness. But that is not happening, doctor, because solitude is something very great to achieve. It's not very easy to achieve, doctor. Thank you once again for an excellent presentation, doctor. As a layman, I could benefit so much. So you think of the benefit that all other doctors who have attended this seminar, and I wish that more and more such seminars are being conducted by you. Thank you, doctor. God bless you.
Thank you,
Thank you,
Mr.
sir.
Yeah, thank you, Mr. Jambunathan. I think thank you for pointing out Biomansa Sanjeevani. I was lucky to be one of the persons who, like all of us started it together. So when DM geriatric course was first started at Demands, the whole department came together, and mainly in COVID this started because we were not able to go for our community programs. So it was decided that this Biomansa Sanjeevani program will be started, and different topics. I think one of the topic was actually on making a will. So how can senior citizens think about making a will, and what are the difficulties sometimes encountered about physical movements, social issues, legal issues. Every week a new topic is covered in different languages. It has run fantastically, and again, it's an honor to be part of the starting team. Now it is run by different individuals from different specialities. Many times the DM students, the professors, other experts in different field. I will also encourage every one of you to attend that. And thank you once again, Mr. Jambunathan, for pointing that out. And yes, just to mention a line, the Western concept of solitude is loneliness is perhaps a little bit biomedicalized. As I was talking about spirituality, and that article of ours, if anybody is interested, I will share. We mentioned about how accepting isolation and reflecting on one's own self, a person can move through this field even when the person is physically away from others. It's difficult task, but definitely it's something which has been time and again mentioned in the Vedas, Upanishads, and I'm sure in different other religions as well. So it's not something which is impossible.
Thank you, doctor. That helps me. And I'm making one more request to Dr. Anand. Please kindly share this video, doctor, so that I can share it with my group. So
Okay,
there are
sir.
many people who are
I will do it,
interested.
sir. I will do it, sir. Yes,
Thank
sir.
you, doctor. Kind of you, please.
Any other questions? Okay, so
I think I can see one question, Dr. Anand, in the chat.
yes,
Is
sir.
loneliness connected with leisure time activities of older people?
Yes, sir. Can answer.
Yes. So to briefly answer it, yes, it is. If you remember the last study that I discussed, it directly talks about the quality of leisure time activities. And I think this becomes very important post-retirement. because once a person has a very set structure going on in the whole day, the person is, engaged. But after any form of retirement, it need not be an official retirement. When a person stops going for regular work, the whole day is without a structure. So having meaningful leisure activities and incorporating your old hobbies, maybe many of my, I remember my grandfather telling me that all that I was doing after I stopped working is I started with plants because I loved gardening all my life. Now there was nothing to stop me, so I can happily do that. So having your old hobbies back, I think it really, really helps a lot in mitigating loneliness.
Yes, sir. There's another question. Can a policy of creating more job opportunity for senior citizens reduce loneliness?
Yes, I think we should all advocate for that. And not only, I would just not say that a job opportunity with an earning, of course, a financial independence is necessary. But as Dr. Rajiv was mentioning, probably any kind of work in which the person gets back their self-worth and they feel that, okay, I am not useless. I am still able to contribute meaningfully to the society and participate. So that feeling is very important. And hence engaging them in various activities, be it financially remunerated or not, becomes very important.
Yes, sir. So I think if there are no more questions.
Mr.
Just-
Partharoy has his
Yes,
hand
Dr.
up.
Partharoy, sir.
Yeah.
Yes, thank you. I'm Partho Rai from Kolkata, a neurologist by profession. Thank you, Dr. Debanjan Banerjee. I really enjoyed your reflective and extremely comprehensive talk on a subject that's very socially relevant. And I also revised the highlights from Madam of the International Longevity Creative Center. I wanted to add some science to the extremely broad spectrum talk that you gave about the neurobiology of loneliness. I know you have given a caveat of the Western biomedical model of loneliness compared to more spiritual model of loneliness that you are trying to say is more relevant in the Asian, Indian setting. I accept that. But are there any biomarkers for loneliness that can be detected early on, which can therefore be corrected or mitigated earlier on? That was one. And of course, I liked your analysis of loneliness and isolation versus solitude. And of course, comes in depression as well. So how much of loneliness is a consequence of euthymic states, dysthymic states, and depression, which remains nascent? That's something very much psychiatry specialization. So that's one. And then,
Yes,
of course, a corollary for that would be whether we can predict individuals who are likely to become lonely in later on life, so they can put in corrective. And with this, are there any imaging correlates that you have done in NIMHANS to give this? So it's a cluster of 3 questions. That's my first part A. So I'll let you, reflect on those observations, questions, please.
Yeah, thank you, and Dr. Partharoy. I think it's thank you for bringing this out. I when I was preparing the presentation, I wanted to include, in fact, certain slides on neurobiology. And honestly, when I was doing my search or doing my review, I thought there won't be much articles because I told loneliness is a very subjective feeling. But there is a huge literature on neurobiology of isolation, neurobiology loneliness, and especially this concept called touch hunger. So we had published something similar during COVID times. It starts from a very basic urge that all of us have of being in physical proximity to the person whom we like. That need not be just a sexual intimacy, but just physical proximity as well. So yes, there have been multiple studies of biochemical imaging as well as even EEG markers that have come across, even though many of them are not very specific. One of the things which has recurrently come across is oxytocin levels, and the other is I point out two very interesting things. In fact, one is the amyloid deposition, which we very well know is a part of, all starting process of Alzheimer's. But today, as the understanding of Alzheimer's has advanced significantly, similarly, one of the things which has been linked to loneliness is the rate of tau phosphorylation and amyloid deposition. And not only in the CSF levels, but also if you look at it through an amyloid scan. So an Australian group has done it. The discussion, the debate is whether these individuals also had a pre-dementia diathesis going on, but definitely those who were in social isolation have seen to have increased inflammatory markers, not only in the blood and CSF, but also similar changes in the brain. With respect to imaging, again, there are so many things, but I just like to point out a very interesting thing. One of the markers that we see in late life depression is often considered as a disconnectivity syndrome. So it's almost like the connection between the frontal and the subcortical structures have been impaired. So when we do functional studies, we often see problems in the DMN network. And this has actually been replicated in social isolation as well. So again, we need to, and that if you actually look at theory of mind is another concept which has so much of implication in social cognition. So one of the areas which are very much involved in social isolation is the inferior parietal lobule and insula. So these two have been distinctly linked with how a person perceives him or herself, this identity of self and connecting it with the identity of others. And similar studies have actually been done in macaques to see whether how they react when they are separated from their groups and kept in social isolation. I think it's a very, very interesting area to explore. And I'm sure that further studies will help elucidating this neurobiological understanding so that we can have some sort of prediction that which individuals are more likely to develop loneliness.
Then as a mitigating and alleviating strategy,
Thank you, sir.
if we manage expectations of individuals as they approach the elder age, and our social structure is changing all over the world, including in India. We are changing our social fabric. And so if the social expectation management of senior citizens or people approaching senior citizenship, that's an important to affect the neurobiology and the neurochemistry of the brain. And as you said, the Upanishads and the Vedas and the reading and this Vanaprastha and all the rest of it, understanding that what's right today may not be there tomorrow. And the children have a right to lead their own lives, as will grandchildren, and friends come and go and people die. So that will leave. So what are the corrective strategies that are in place, particularly for India, Bharat? Because the working population at age 60 is media dependent, television dependent, Facebook dependent, and then all of a sudden there's a vacuum when they retire. You touched upon it. How do people manage retirement? So some thoughts on that, and that will be my question. Thank you very much.
Thank you, sir. Sir, just take one take-home message from our valued guest today, Dr. Debanjan Menon, sir, and Mrs. Anjali Raje. Just one take-home message, what you like to give regarding loneliness. This will continue. This will go on continuing. It's not the end. This is just the beginning, just to create awareness among geriatricians, postgrad students, and the general people who are working for the betterment of the older people, the NGOs. So this was the step to create awareness. So one take-home message, sir, from you, and then we'll have from Madam, and we'll wind up.
Thank you, Dr. Anand. I think I will just merge my take-home message with what last question of Dr. Partho. I think it is important and imperative for all of us working in this specialty to come together to understand that loneliness doesn't happen one fine day. It's a process. So it's a responsibility at all levels, at an individual level, at a community level, and at a policy level. And we need to keep advocating. So as I mentioned, if we have to create an age-friendly society, charity begins at home. Let us all start within our own small circles and then just keep it widening up. Thank you.
Thank you, sir. Exactly. Even my mother-in-law is attending this program. So I started it from home. Thank you, sir. Over to you, madam.
Yes, actually, as a not-for-profit organization, I think most of our role and responsibility would be working towards creating awareness on this issue of population aging, uh, advocating the need to understand the concerns and issues of the older persons, and how best we can, through our own small ways, come up with interventions that would, as we all spoke about, alleviate not just loneliness, but also create a sense of self-worth amongst the older person. So we are working towards that through our various programs, and we hope that the rest of the not-for-profit organizations and other individuals working in this domain also come up with interventions that would work towards this cause of population aging. Thank you, Dr. Ambali. Thank you, Dr. Banerjee.
Thank you, madam. Over to you, Dr. Vignesh.
Thank you, sir. I'd like to propose the vote of thanks. It is a great honor and privilege for me to propose vote of thanks on this occasion. Firstly, I would like to express my gratitude to Dr. Arvind Patil, sir, Dean Faculty of Medicine, Shri BM Patil Medical College, Hospital and Research Center, for allowing us to conduct this event. I'd also like to thank Ms. Anjali Raje, Executive Director, International Longevity Center, Pune, for chairing the session. And I would also like to thank the respected faculty of the today's session, Dr. Debanjan Banerjee, Consultant Geriatric Psychiatrist, Apollo Multispecialty Hospital, Kolkata, for his critical inputs on this topic. I would also like to express our gratitude to our collaborating organization, GSI. I would also like to thank our HOD, Dr. Professor Anand P. Ambli, for organizing this event. And lastly, I owe special gratitude to all geriatrics department staff of the department, including moderators of today's session, Dr. Mudassir Endikar and Dr. Aprarullah, and also coordinators of the session, Dr. Anirudh Umaji sir and Suma Rathod ma'am, and PG students of the department for the assistance in managing this event. And once again, thank you all for your attention. Thank you. Have a good evening.
Thank you, sir. Thank you, madam. Thanks for with us. Thanks to all the participants. Thank you so much. And we'll take your leave.
Thank you. Thank you. Thank you, Dr. Anand. Thank you,
sir.
man. Take care, please.